Dear regards to all the stalwarts of neuro-ophthalmology present here, and a very warm good afternoon to all of you. So I am here to present on neuroimaging in ophthalmology from a general ophthalmologist point of view. So as said by father of neuro-ophthalmology, neuroimaging is that subspecialty of ophthalmology where diagnosis is made upon the reinterpretation of alleged normal scans, and hence the importance of neuroimaging. So the question arises, why to order, what to order, and when to order? Well, as we all know, neuro-ophthalmology is a little bit complex topic, but it has been revolutionized by the current imaging modalities, and the diagnostic yield is optimal when the ophthalmologist and the radiologist collaborate in the radiodiagnostic workup. And we all know that the person who does these scans, namely CT, MRI, he is a technician, he is not a doctor. So unless we specify what we are suspecting, where we are suspecting, and many times patients, especially in periphery, in government setups, they may not ready to go to a neuro-ophthalmologist, it may not be available in the city. So our aim should be to make a diagnosis and then to refer so that we can explain to the patient the seriousness of the case, or whether he or she can wait. So what are the problems faced by a general ophthalmologist sitting in a busy OPD, especially in periphery, in government setups, and also in private practice with lot of bread and butter cases to dispose of? We often tend to keep these special cases at the end, and we often get confused what to write CT, MRI, what exactly to write CT brain or CT orbit with contrast, without contrast. Then we have the tendency to refer at the higher center without arriving at a proper diagnosis, and we also have a tendency to straight away look at the report instead of the film. So what are the errors in neuroimaging? These are the prescriptive and interpretive errors. Errors on our part could be failure to order request for a correct study, omission of contrast or specialized sequence, and interpretive errors like misleading clinical information and low sensitivity of imaging. So I will quickly discuss the common imaging modalities, pitfalls, and the common clinical conditions. These are the gamut of imaging techniques which are available nowadays with CT, MRI, lead array of detectors instead of a single X-ray plate. And this we get based on the attenuation caused by different tissues. We get an image like this, and so it is basically a densitometer, and based on the density of different tissues we get the images, and where water and air, they have negative densities and they appear black, water appears neutral, and bone appears white on CT scan. So disadvantages, as we all know, radiation, contrast allergy, and osseous artifacts, but the advantages of CT are less time, less expensive, and it is indicated in all cases where MRI are contraindicated. Indications I'll discuss one by one. So what are the things to keep in mind before ordering a CT scan as a general ophthalmologist? Slice thickness is the most important, because unless we mention the slice thickness, the normal slice thickness for CT scan abdomen or any other part is 10 mm. And for ophthalm, you have to remember that for routine we have to mention 2 mm cuts, and if we are suspecting something of the optic nerve, we have to mention 1 mm cut. Because if there is a tumor of say 5 or 6 millimeter, and if we don't specify, and if the technician is not that well expert, we may easily miss. So we have to order CT brain orbit with thin 2 millimeter cuts, exactly we have to specify. Then regarding contrast, in cases where we are suspecting vascularity, to know the surgical approach and whether how much it is enhancing anything which will give a contrast. If it is vascular, it will enhance. So there comes the role of contrast. Then imaging planes in CT, normally we get only axial images, and the coronal and sagittal, they are reconstructed. So this is the Reed's line, which is the orbitomeatal line passing from the inferior orbital rim to external auditory canal. Any line parallel to this is the axial, and any line 70 degree to approximately 70 degrees is the coronal, because if it is 90, it will the teeth will get the artifacts. So tissue window is one thing which we should important. There are two tissue windows, soft tissue window and bony window. Like in this image, we can see that the bone, the lens, and these soft tissues, they all appear to be of the same density. And here it looks like there is a medial wall defect, so we cannot clearly say. So we have to order a bony window in which the bony details will be clear, and we can see that all the bones are intact. So, and we have to also keep in mind that like special techniques like in patient with orbital varices, if we don't specify, like we have to perform CT with while doing Valsalva, it may be missed, because in supine position it will not be visible. So normally we don't get a single scan, we get a series of scans like this. and the images are from caudocranially, that is from bottom to top. And in if we use this lens and the optic nerve as the landmark for mid-axial scans, we have to see few images above and few images below it. Like, and this, whenever you are ordering CT orbit, please mention the cut size, as I said, 2 millimeter cuts, because in this they have given 5 millimeter cuts and you can see very few images of the orbit. So mention the cuts, and these are the coronal scans which we get. So I will quickly rush to the indications. In cases, any cases with in which bone is involved, you have to order a CT scan. Like in optic canal fracture, here you can see in the right side there is the avulsed and retracted optic nerve. Any cases of orbital floor fractures, RTA, these are very common presenting in any government setup or in periphery. So just to remember, you have to always ask for the coronal reconstruction in suspected orbital fractures, because in normally they carry the axial images with the patient party, and if we look for fractures, we will easily miss. So always ask for coronal reconstruction. And as I mentioned, order for CT brain and orbit non-contrast, because in fractures you don't need contrast, thin 1 to 5 millimeter cut. These are special techniques, volume reconstruction techniques, in which you can easily see the cut and plan the surgical management, whether it can be managed conservatively in the periphery, because many times patients are not ready to go outside. Whenever a patient presenting with bilateral proptosis coming to the OPD, order a CT scan, and like in this case, most common is the thyroid eye disease, and the CT scan findings include enlargement of the muscles with sparing of the bellies. And in this, the coronal image you can see for comparison of the both the eyes. And so it's also in this also you have to ask for the coronal images for the comparison. Just a word about thyroid pseudotumor. In comparison to thyroid eye disease, in pseudotumor the whole of the muscle along with the belly is enlarged. So also in orbital infection, especially in children, to differentiate between preseptal and septal, in this you can see in the left side the opacification is situated just anterior to the septum, and the periorbital fat is clean here. So it is just preseptal, and in septal there is opacification of the periorbital along with this proptosis. So this in any foreign body you have to first order a CT scan, because as we all know, MRI is contraindicated in metallic foreign bodies, and many a times the nature cannot be uncertain. So quickly I will rush to MRI. It is just based on the principle of excitation of hydrogen ion, and as we all know, our body is made of 70% water which contains hydrogen ion. So when we give a brief magnetic pulses, these excite, the ions get excited, and it comes back to its original state, and this sequence is captured, and there are two basic sequences, T1 and T2. Important thing to remember is T1 is good for anatomy and T2 for pathology. And how to distinguish? Just remember that water or any fluid is dark in T1, and so in vitreous and the adjoining CFS it is dark in T2. So these are the modifications. Just a word about flare, because whenever a lot have been discussed about optic neuritis, whenever you are suspecting optic neuritis, if you don't have so much, you just order MRI brain orbit along with the MS protocol, multiple sclerosis protocol. And just a word about flare, as I said, in T2 the CSF is bright, but in optic neuritis we have to search for the demyelinating plaques. So the intensity cannot be, so in flare what they do, the CSF signal is suppressed, so we can find out the this diffusion mating I will skip. So just in optic neuritis, as I said, this is the case of optic neuritis, and this is the enhancing optic nerve. So order for contrast brain and orbit with fat suppression and along with fair sequences. And also such patients coming to the OPD, 45-year-old presenting with diminished vision, and on like we can see the pallor and along with collaterals, order an MRI, because in cases where you are suspecting optic nerve, order an MRI, do the diagnosis and then refer the patient. In this case we can see in contrast MRI brain and orbit the typical tram track appearance, the optic nerve traversing through this. And so just a word about differentiation from optic nerve glioma, in that you can just see the enlargement and you cannot see the track of the optic nerve. So in cases presenting with any cases in which we have fields respecting the vertical meridian, do order an MRI, particularly cellular region, mention the cellular region, and then you will get this typical snowman of 8 or the figure of 8. And also in patients presenting with complete ptosis and pupillary involvement, do order a CT scan brain and with contrast, and you can see this aneurysm of the right posterior communicating artery and CT angiography. just to, even if it is not available, you can direct the patient to refer. So the take home message is to do look for the film along with the reports and try to work up the cases before referring to neuro-ophthalmologist, correlate clinically and do properly communicate with the radiologist. So after all that shades of black and white, colorful, thank you.
Thank you. Thank you so much. It was very nicely covered. Any questions for her? Any comments? I mean, one of the sure signs that neuro-ophthalmology is becoming quite popular is that we have a leading cataract and refractive surgeon of India sitting here in a neuro-ophthalmology session and attending.